The first session this afternoon is commissioning for the long-term conditions. Do we know what commissioners actually do? It's Judith Smith, who's Director of Policy at the Nuffield Trust. She's a very experienced, widely published health service researcher and a policy analyst. And she's going to talk for about 20 minutes, and then we'll take some questions at the end. Judith.
Well, thank you very much, and good afternoon. And yes, I'm from the Nuffield Trust, which is a charitable independent research foundation based here in London. And what I'm talking to you about this afternoon is a 2-year research study that we carried out for the National Institute of Health Research and that we published in March just this year. And there's a nice concise summary of the research on the Nuffield Trust website, and also a link to the full source report should you be interested in reading the whole report. What I'm going to talk about is briefly outline to you the study and what it was we were interested in. It was clearly about primary care trust and practice-based commissioning. It was very much about the nitty-gritty of commissioning. As the title says, what is it that commissioners actually do? But I think those findings are highly relevant to the work now of clinical commissioning groups, and indeed as they work together with NHS England. So then we'll obviously focus mainly on what we found about the practice of commissioning, but then with a few thoughts about the implications of these findings and just a few questions that were left that we felt we had at the conclusion of the research. So the study itself. So we were trying to find out about, it's the practice of commissioning, what commissioners actually do, and particularly in relation to long-term conditions. You can see there the period of time over which it was carried out from March 2010 to February 2012. So it was also a study as so often with health service research in this country, of transitional arrangements being put in place for particularly commissioning organisations. And there you can see it was funded by the Health Services Delivery Research Programme. It was a broadly ethnographic study with mixed quantitative and qualitative methods. We gave regular feedback to the sites and worked very closely with them during the project. It's important to note that we originally selected the sites because they were what we deemed to be high-performing primary care trusts. A whole range of metrics we used to determine that. And then you can see the sort of data collection we did, observing lots of meetings, many semi-structured interviews over the period, and an analysis of a huge amount of documents. It was not always the most exciting of projects for us from a research point of view. There were 3 commissioning communities that we studied. They were always named and in the public domain. You can see there they were Somerset, the Wirral and Calderdale in Yorkshire. Now, we studied the commissioning of diabetes services across all 3 of those PCT areas. And then each place was able to elect a particular service or area of commissioning that they'd like us to examine in detail. And you can see there that Somerset elected for us to look at stroke services, and Wirral and Calderdale both chose dementia. Now, within that, we focused on 6 areas of actual commissioning activity that we really honed in on at lots of detail to try and track through how the commissioning took place and what happened as a result. And you can see there it fell into actually 3 services that were new services that had just begun operation, that had just been commissioned. So you can see there in Somerset, remodelling diabetes care into a 3-tier service with a lot of focus on the kind of the sort of community service level between primary care and hospital services. There was an early supported discharge service for stroke in Somerset. And in the Wirral, they recommissioned part of the dementia services to put in place a new community-based diagnostic service for dementia. And then the other three developments we ended up tracking were ones that were being sort of discussed and planned throughout the time of the research, throughout the 15 or 16 months of active research. And you see there in Wirral, we were looking at diabetic podiatry and how that might be provided in the future. In Calderdale, they were looking at their diabetes services at quite a strategic level. And also in Calderdale, they were reviewing their dementia services. So that's the lenses through which we were observing what went on in terms of the practice, I say the nitty-gritty of commissioning. This is the core of it. What did we find? I've got 6 slides in this section, and they're set up in this way with, I've called it an assumption, but it's almost like a straw man on the left-hand side, which is sort of what you might expect, and then there's what we actually found. So first of all, in terms of the practice of commissioning, you might assume that, the commissioning cycle that you have where you assess needs and specify services and contract for them and so on. You might expect that sort of quite neat cycle to be followed, given its prominence in NHS policy. But we found something much messier. It felt sometimes it was more like a spirograph, if you remember those from when you were young, with lots of different overlapping circles. So the process wasn't sequential, and it certainly didn't fit an annual cycle. And really interestingly, we found that in addition to the sort of activities you'd normally have in the commissioning cycle, the commissioners had quite a central role in convening and coordinating all the different sort of interests and stakeholders locally in the health economy. So bringing together patient groups, the local authority, the providers, commissioners, for example, to review dementia services, sort of holding workshops, bringing people together, specifying services in that way. And the other possibly additional role we found that isn't usually in the commissioning cycle was commissioners actually playing a role in supporting implementation of things they commissioned. Quite a strong project management role, helping to see through that the particular new service was actually happening as planned. Secondly, and if I could only sum up the project in one phrase, it would be this one: the labour of commissioning. Now, one might assume that commissioning is very much those with the money incentivising others to do some work, to put in place services. But we found a huge amount of time and effort going into commissioning. And this was before the 40% management cuts that we've subsequently had. And it was verging on overwhelming at times, the scale, I say, of this labour of commissioning. And we did feel, certainly in some cases, we weren't sure the scale of that effort was necessarily related directly to what actually was brought forth in terms of changes to the particular service. A lot of that labour was associated with collecting and handling data. And also we found that decisions about making priorities in terms of what commissioning activity to do or not do was often just plain and simple based on the resources that were available to actually do all of this work and do it in a way that was expected in this very collaborative, involving way that people seem to expect commissioning to work. And who were the commissioners? Well, again, as I said, you'd assume it's those with the money who are giving that out to meet some particular needs. But we found it was actually, again, more complicated than that. It was multiple and sometimes ambiguous. Providers were playing often quite a central role in commissioning tasks and events. Now, this may have been partly because of the time of transition, and sometimes they were, deciding to hold a workshop on the future of dementia services or do some detailed modelling about the future of dementia diagnosis clinics or so on. But nevertheless, it did feel that it wasn't as simple as the commissioners here and the providers there. It was a much more interactive, collaborative activity. And as I mentioned already, the commissioners, of course, were then, they were reaching across the purchaser-provider split because they were helping to shape and track and undertake some of the implementation of new services. There were very interesting shared responsibilities across councils and PCTs. We saw quite strong, what one might call joint or collaborative commissioning in that sense. And also clinicians in many different roles. Now, of course, you've got the practice-based commissioners, the GPs and their nursing and other colleagues being commissioners. But interestingly, hospital and mental health provider clinicians often playing quite a strong role in the commissioning process, leading teams from the providers in terms of planning and working with commissioners. Our fourth observation is about money, which again you'd expect commissioning to be, at least to a fairly significant extent, about money as well as about needs and services to meet those needs. But we found that money was often it wasn't mentioned a lot often in a lot of the commissioning meetings and work and interactions and indeed documents. And it seemed to often appear quite late in the story, almost when the service specification had been sought out, decided how to move forward. But it often felt to us as well as though it was happening over here, that perhaps the deals were being cut by the finance colleagues, whereas it was these people called commissioners, the clinicians and perhaps middle and fairly senior managers were doing the actual commissioning work. So we got some questions about how far those two actually were drawn together. And then the nature of change. Again, you'd assume that commissioning, given the amount we invest in it in this country, that it would be about enabling abrupt sometimes or radical or significant change to be made, and also to stop providing services or to actually reshape them in quite a different way. But we found that change was often very slow to be brought about, and some of the services we were observing, hadn't been sorted out by the end of the period of the research. We found that commissioners were very much part of their local health economy. They were sensitive about disrupting that economy. And because change often involves moving staff between organisations, that's costly and difficult to do. It's costly in terms of management time in HR terms. And it certainly seemed that it was easier to commission for, or of course bring in something new, than it was to actually decommission or stop doing something. And a point that has to be made was that senior and sustained project management was critical, and particularly middle management. And colleagues at Manchester University who've been studying commissioning in parallel to us, they talk about the middle manager as animateur, the French word, the person who makes things happen, who brings things to life. And we absolutely saw that again, the critical role of those people who often have long experience of, say, mental health commissioning. And the final sort of topic in terms of these core findings is about the sort of role of national guidance. Now, again, the rhetoric of commissioning is very much about local decisions being made by commissioners, but we found that the top-down impetus to get things done does make a significant difference. So whether that was some particular policy initiative about, national dementia strategy or the stroke strategy or whatever it may be, those things would often suddenly bring forth particular activity and focus. And a wide range of strategies and models of what to do were used, and they came from other places, such as royal colleges. And then the local commissioners, I think, were pretty savvy at often using that national guidance to press ahead with work they wanted to do locally. Just as I move towards concluding, just 4 slides here with some thoughts about kind of the implications, just trying to draw together our findings for the world we're now in. Commissioning, particularly for long-term conditions, and it was long-term conditions we were looking at, but is made up of multiple and labour-intensive processes. Now, some of these clearly aligned with the commissioning cycle, but others didn't. So the things like the commissioner's role in convening, the commissioner's role in supporting implementation, and some were conspicuous by their absence. We did not see a lot of use of data to challenge the performance of services, and we didn't see a lot of that review being used to sort of feed into the next phase of commissioning. There was much more around service design, if you like, and involvement, the more relational part of commissioning, and much less about the transactional side. Commissioning practice seemed to us to be often much more about incremental small changes and not very often about whole programmes of spending or activity. And decommissioning didn't feature very much. The only significant example of that was in the Wirral dementia services. So as I just mentioned just now, in what we observed, it was the relational aspects of commissioning that seemed to dominate. So all this time and effort going into the design, specification and engagement, that work was clearly critical in bringing about change. But we had some questions about the point at which commissioners have to decide to, in a sense, get transactional, in a sense to stop consulting, stop involving, stop all the service design sort of activity, and in a sense get on with the contracting and the negotiation part of it. And I think there are some quite tough questions for commissioners now. I'd be interested in responses from those of you who are commissioners about how far can you afford this relational commissioning, which we wondered is partly rooted in NHS culture, is that possible to sustain now in the reformed NHS? The cycle of commissioning clearly gives some order and routine to commissioning, and it helps them commissioners tie in with the annual financial year. But long-term conditions, they're not easy to sort of split up and commodify in a way that you certainly can with elective surgical services, for example. And we were in our conclusions saying perhaps it's time to think differently about how we work across commissioning and providing, particularly with long-term conditions. Do we need a different approach to risk sharing and contracting? Do we need to explore the accountable lead provider model more, or alliance contracting? Some of these different approaches where perhaps a larger budget's given to a provider to kind of go forth and commission and organise a whole set of services. And finally, I think it's important as well just to dwell on what we saw as the critical enablers of effective commissioning practice. Skilled managers, and I've mentioned the middle management level, people who can span the boundaries of different organisations, and indeed different directorates within the commissioning organisation. And that'll be even more the case now with commissioning support units, local area teams, and so forth. Accurate and timely data. Data was often seen as both a help and a hindrance. It was quite a puzzle to us at times, that one, how that was working out. A judicious amount of meetings and workshops. So that's back to my point about at what point do you stop consulting and involving and sort of get on with the transactional work. Careful use of national guidance at the local level, and clarity about the outcomes expected of commissioning. Because we did find at times that commissioners found it hard to, when you really ask them, what is it you're trying to achieve in terms of outcomes for users from this commissioning activity, sometimes found that hard to define. So this is my very final few questions that some of the ones we've been pondering as we've been doing further writing and thinking and discussion with colleagues in the NHS as a result of the research. I mean, there is this question I've already posed, really. When it comes to this labour of commissioning, how much is too much? And then, to what extent does this blurring of roles, the commissioners helping with implementation, the providers getting involved in the planning activity, does that matter? Or is that actually appropriate? Are people out there, in a sense, making sense of things? And is it perhaps the sort of the mechanisms of commissioning that haven't, in a sense, caught up? And should money have a more central and specific role in commissioning conversations? And the final one, are commissioners to some extent, have they been held back by caution or by constraints? So is it sort of cultural, or have there been just things that have just made it difficult? My final question is, will clinical commissioners be more radical? Thank you for your attention, and I'm more than happy to answer questions now. And I say do look at the summary or the full report of the research if you're interested in finding out some more. So thank you.
Well, thank you very much, Judith. Excellent. We're going to take about 10 minutes of questions. Can you wait till you actually get the microphone before you ask your question? Thanks very much. Is there any questions? Here's one.
Hi, Gina Plumbo, GP from East Riding. I'm chair of a clinical commissioning group. I'm just wondering about when the synergy of working of managers and clinicians, whether we really will see, I think this is part of your last question, whether we will be radical enough. I mean, when you're saying, do we need this relational meetings and facilitation, we absolutely do, because the managers didn't know how to commission these complex pathways. The clinicians only know part of the complex pathway, so you absolutely, I would suggest, need to continue that relational setup, which of course then we're being pulled apart because of the competitive, conflicts, etc. So, huge tension.
Yes, I mean, I think you're making a comment in a sense, weren't you, more asking a question, but a very important point there about the competitive new regulatory framework, which I didn't cover today, but we are doing other thinking and planning, other work to explore that sort of going forward, because that really in some ways feels like a clash of cultures at times to me. And I mean, just as a more general observation, when I look at the current programme of health reform, you feel like sometimes the discussion about integrated care, and if you read the papers about the pioneer sites and so on, which is hugely encouraging, but when you read them, it feels almost like a different universe from if you read, say, the guidance from the Cooperation and Competition Panel about clinical networks. And I'm not convinced that those two, they're sort of being held in tension by you guys because you're having to out there. But I don't think they're resolved in policy, or I'd probably argue political terms as yet. And I think that's at the heart of the challenge you're going to face. So,
absolutely. Any other questions? Must be another one. There we are. Front here.
Hello there, Graham Ruston from Richmond Clinical Commission Group. You talk about the labour of commissioning. I'm guessing from my point of view, I'm looking at that as seeing it's the balance of risk, and where you have the private sector and other areas where risk is very key to their decision making, and where we are very risk averse. How do you see that making a difference in the labour of commissioning, and where we need to maybe start to take or expand our risk areas so that we actually move forward rather than being held back?
I think if you like that laborious nature, if that's the right word, or that labour of commissioning, it might be partly about being risk averse, but I do think, for me, there is something more profound about the culture of the NHS and how it has worked over such a long period, and how people kind of almost expect to plan and specify services and work. And, you know, it almost makes you wonder if, despite all these attempts to have an internal market over the years, the NHS has, I always think it's like a big shock absorber against efforts of politicians in terms of policy, that it has somehow managed to keep going with this very collaborative, involving sort of way of planning services. But the other thing I think about that is that I do think long-term condition services, I think the complexity of the patterns of care people have across health and social care and other providers, including private providers, means that it is particularly probably needing that more collaborative approach. So going back to the risk point, that was why I'm then left thinking that we need to perhaps share the risk differently. The purchaser or the commissioner trying to share the risk with all these different providers probably doesn't work, but I say finding a way of letting a whole accountable contract or a capitated contract to a group of, whether it was GPs or GPs, nurses and others, some sort of federation to manage care. For me, there's more skin in the game there, I think, to pursue, because I think then you're handling the risk at that slightly broader sort of level. So in a sense, I don't blame them for being risk averse with some of the complexity they're dealing with these sort of services, when doing something to one bit ricochets right through potentially a whole pathway, for want of a better word.
Well said, indeed. Any more questions? There's one here.
Some over there as well. Hello.
Hello, Wistwood. Thank you very much. I think an awful lot of what you've said absolutely resonates as being true in our area, and I'm sure it does for anybody else in CCG land. There's a certain amount of pessimism in some of your conclusions, in that it seems that the word inertia is written pretty large in a lot of what you've found. Do you think a better model might be the accountable care organisation model?
Yes, I mean, I'm sad enough to have been researching commissioning for nearly 20 years in its different forms. But I think this project has in a sense, I mean, I've been wondering about commissioning for quite a while in terms of its overall effectiveness, and this project has really made me stop and think about, you know, is this actually the best way to go? Are we, in a sense, trying to impose this divide and spend all this time working across it and trying to deal with, I mean, I know conflicts of interest are important, but you know what I mean? We get so hung up on a lot of that it's back to my point about, I think it probably is time to, I am quite attracted by at least testing out, as people are doing and have been doing for a while, the accountable lead provider model. I know they've been doing it in Oldham, and I think they're looking to do that in Bedfordshire now, and where people have done that for things like musculoskeletal services, people are now trying to say we could do that for frail older people, which in a sense I think is along the way to some sort of accountable care organisation. But I think there's ways we could do it in between. But I'm also very interested in whether it's federations or networks of practices and other providers, and the potential they have to take on budgets and risk and actually run services in quite different ways. And if I'd had my time, Regina, we wrote about this back at the last election, I'd have had fewer larger PCTs and let all of you as CCGs be those accountable care kind of organisations. And but who knows, we might yet end up back with something like that, because primary care and commissioning land is very good at making sense of reforms, and I say, and getting on and making things happen in the way you want to. So
thank you very much indeed. That was really, really good, and very much food for thought. Some of those things are echoed by me, actually. I've been thinking the same thing as you. Anyway, I think that we'll wind that session up as we're ready for the next one. Thank you very much to Judith for an excellent presentation.